afternoon and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend some time with us this busy afternoon, but we think that you will find that your time will have been well spent. Dr. Maxey is en route. I don't know if he wants to speak en route or whether you want me to just move on with our introduction.
I can speak for a moment.
Well, then go right ahead, Dr. Maxey.
So thanks everybody for joining us. We have a treat. One of our best speakers is joining us. His name is Dr. Brian Stone, and his topic is prostate cancer. I spoke to him early this morning. He happened to be cruising in the south of France right now with in-laws, enjoying the good weather. So we're going to do his February talk because I think prostate cancer is still a major danger to men of color. And with that, Barbara, would you please do his introduction?
Oh, certainly. It's my pleasure to reacquaint us to those who have been with us before and to those who are joining us for the first time. We're having an outstanding talk given by Dr. Brian Stone, who is an Alabamian and did his initial training at Rutgers and then Morehouse School of Medicine and UAB School of Medicine. He is a diplomate of the American Board of Urology. He specializes in urologic oncology. He also has done fellowship in pediatric urology. So you see, Dr. Stone knows his field very well. He has been engaged in a number of community-based activities promoting or providing community information and access regarding prostate cancer, a disease that has like so many others, seems to have a particularly devastating effect on Black males. Without further ado, Simon, would you please run our show?
We are not hearing the audio as yet, Simon.
You said there was no audio?
Correct.
That's correct, not as yet.
Okay, hold on, let me redo it.
From prostate cancer, today we're going to revisit the world of prostate health.
Dr. Barber, Neighbor Stevens, Dr. Walks, Dr. Hines, and certainly our special guest is Dr. Brian Stone. And this topic is very personal to me. Some years ago, when I had a diagnosis of prostate cancer and had a surgery to remove it, and I met with Dr. Stone, and he said, there's a drug that starts with a an S, and I want you to take it like it's candy. Some people know it as the blue pill, but it worked. And I've been his fan ever since. And due to the fact that we have still a high incidence in our community, including our Secretary of Defense and a number of our colleagues still getting prostate cancer, we need this information to help us survive. Dr. Stone, I'm going to ask Dr. Neighbor Stevens if she would introduce you with some of the details of your training, and then the floor is yours, sir. I respect you
Okay.
very much and thank you for the advice you gave my life.
Oh, it's my pleasure.
Well, we are very happy to welcome back to Black Health Trust someone who has impeccable credentials in the field of urology. He is a native of Alabama. He has finished his training at great institutions such as UAB School of Medicine.
What is UAB?
University of Alabama in Birmingham.
Oh, yes. I'm so sorry.
That's all right.
Don't want to slight that. He is boarded in urology and is a well-recognized authority in urological science as well as a researcher. And we don't have enough research going on in our community, so we need to highlight and elevate our colleagues who are aggressively attempting to fill the void of data that we suffer from. Without further ado, it is my pleasure to turn it over to Dr. Stone.
Well, thank you. It's a pleasure to be here. I appreciate you guys having me back. Since I spoke about prostate cancer the last time, I decided to change the presentation a bit. Am I sharing screen right now?
Not yet.
You want me to try?
Yeah, go ahead.
Okay.
Okay, we can see it.
So I'm currently the president of Jasper Urology Associates, which is a private practice in Jasper, Alabama. We're at Walker Baptist Medical Center, which is a regional medical center servicing about 900,000 people. We are the only center for about 5 counties. I'm also very proud to be an executive board member of Conduct, which is a Black consortium on disparities of urologic conditions. And we have just launched the SCOPE African American Prostate Cancer Registry Trial, which we hope will be the largest repository of information on African American men with prostate cancer. And I'm also the founder and CEO of Clinical Diversity Solutions because the traditional model of recruiting patients to participate in clinical trials just has not worked. That means going to physicians and getting them to recruit patients to participate. One of the big problems is that there aren't enough Black physicians. The numbers are actually going down. And because patients can go anywhere, not all Black patients go to Black physicians. So we need a better recruitment model. So that's what I'm working on right now. So what do all these Black men have in common? Dexter King, I'm sure you've all heard about him having recently died from prostate cancer. He was someone I knew, and I have several friends that knew him well. He became very private, probably presented late in his diagnosis, even though he was a young man. General Lloyd Austin similarly did not handle his diagnosis well. General Colin Powell, Sidney Poitier, I worked with Harry Belafonte, who was very open about his diagnosis when I was in New York, and promoted early detection. Al Roker has also been vocal, Shannon Sharp, uh, Ken Griffey Sr. I work with Michael Haynes, who helped pass a bill in the 90s supporting PSA screening. So prostate cancer does not discriminate. It doesn't care who you are, if you're a celebrity or whatever. It will take out anyone. It is called the silent killer because it is asymptomatic in the earliest stages. So you don't feel anything. So the typical thing you hear from a black guy is, look, I feel healthy, I feel good. That's the time when it's growing. By the time you're symptomatic, you're probably in an advanced stage. So prostate cancer is the largest cancer disparity in the United States. Even after all these years of promoting PSA and all the other screening activities, it continues to be the largest disparity amongst Black men and everybody with cancer. Black men have a 2 times greater risk of dying from prostate cancer and almost a 2 times greater chance of being diagnosed. And this has been pretty consistent for the since records have been kept. I can say that the mortality rate, which was almost 3 times greater in the 90s, has come down some with the creation of the screening test PSA. Um, but one of the major problems is that as new treatments are developed, these new developments are based on data collected from participants in clinical trials, and Black men represent less than 8% of the participants in prostate cancer clinical trials. Now, access to early detection is not one of the main drivers of racial disparities. There are a lot of complex factors that are impacting this huge disparity between Black men and white men. Um, Genetics and cell biology, with the completion of the Human Genome Project, we have really identified significant genetic factors that seem to impact the veracity of prostate cancer in Black men. Uh, we've all heard the term social determinants of health. It is a major factor. Where you live, how much money you have, do you have insurance? Do you have transportation? Do you have childcare? What's your educational level? Institutional racism plays a major role. There are several studies in in the 90s and early 2000s showing that patients presenting with the same diagnosis, like say renal failure, Black people were more likely to be given dialysis and a white person referred for a transplant. Black men with prostate cancer are more likely to be referred for radiation therapy versus a more curative surgical procedure. There's a lot of new science that's emerging about other factors that drive disparities in prostate cancer. Um, so the VA, which is a good system of equal access to care, has done several studies that have pretty much shown that access to care does not guarantee equal outcomes. Um, so I made racial red because race is a social construct. And what genetic research has shown is that race has nothing to do with anything, and it actually has a negative impact on data when patients are allowed to self-report by race. We should be looking at genetic differences in prostate cancer cell biology. What we know, Black men tend to have a higher baseline level of free testosterone. Black men with prostate cancer exhibit increased androgen receptor signaling. They have increased genomic instability. increased metabolic dysregulation, increased inflammatory and cytokine signaling. These all seem to make the prostate cancer more aggressive and at a higher Gleason score, which is how the cancers are graded pathologically. This was a huge study, and it showed that a multitude of data supports the hypothesis that systemic discrimination, racism, and socioeconomic difference are major drivers of prostate cancer disparities. And I dare say all of the diseases that disproportionately impact Black people are impacted by the same things. The true incidence of prostate cancer in the United States is that 1.76, a Black man is 1.76 times more likely to be diagnosed with prostate cancer. Black men are 2.14 times more likely to die from prostate cancer. We are much more likely to present at a younger age and present with advanced disease when the diagnosis is made. 9.6% of Black men are uninsured compared to 16.7% of Hispanic men and 5.2% of white men. And while both Black and Hispanic males face the same barriers to healthcare, Black men have the highest incidence of mortality from prostate cancer. This means that there's more going on than just access to healthcare. So this kind of supports the notion that there are biological factors driving the different outcomes. And we don't have enough data about social determinants of health, but I am certain that there are environmental factors that are impacting our genes. One study identified a gene that seemed to travel with us during the Atlantic Passage and slavery. And Black men we were deposited in the Caribbean, we were deposited in Brazil, and we had the same gene that came to the United States. But for whatever reason, we in the United States have the worst form of prostate cancer. So some of us have discussed it, and we think maybe the severity of slavery in the United States was a epigenetic factor that had for some reason turned on genes that made our prostate cancer worse. Uh, we know redlining has always put us in the worst places, more toxic exposure. So there's a lot of data that needs to be collected to help us kind of tease out why we have the worst prostate cancer in the world. There was a study that showed that as socioeconomic status increases for white men, prostate cancer mortality rates decrease, but in Black men, it has no impact. I mentioned this earlier, but this was a study that looked at a equal access health system. One of the problems was the cohorts were small, but they looked at 300,000 Black men in one study, and they compared them to white men. And when there was equal access, and I highlighted when the patients are given the same treatment, the prostate cancer survival became equal. So that's where systemic racism is an issue. We're not always given the same treatment. I mentioned this when I gave my last talk, but I think all of you are aware of the United States Preventative Services Task Force recommendation against PSA screening in 2012. And for about 6 years, PSA was given a D grade. Well, the behavioral risk factor surveillance system reported significant decreases in PSA screening during that time. And as a result, the incidence ratio of localized prostate significantly increased in Black men compared to white men during this period. And we saw considerable increases in the mortality rate in Black men and presentation with more advanced prostate cancer. And we are still recovering from the impact of that recommendation. And this is for both Black and white patients. Since that time, I've been seeing patients getting to me with much higher PSAs. The primary care physicians are sitting and waiting and treating patients with antibiotics instead of sending them immediately to a urologist to be evaluated. Um, the addition of the MRI has reduced the need for prostate biopsy, so there's no reason to hold out on referring a patient for a PSA that is either elevated above what is considered normal or has an abnormal PSA velocity. If a PSA increase is greater than 0.75 nanograms per milliliter in a 12-month period, that's abnormal. So you should send that to a specialist and let him figure out whether this is something significant or not. Military service can result in aggressive prostate cancer. I take care of a lot of veterans who unfortunately were exposed to Agent Orange, burn pits. Uh, since the Gulf War, a lot of the munitions used depleted uranium. So they're being exposed to radioactive materials and other chemicals, and these have been associated with much more aggressive prostate cancers. Black servicemen, even though the rate of prostate cancer increased in Black and white men, the Black servicemen had higher Gleason scores and more aggressive prostate cancer than their white counterparts. So this suggests, again, a biological factor. So there appears to be a dance between non-biological, like factors like social determinants of health, and biological factors in the promotion of health disparities. Prostate cancer-related loci in Black men appear to play a greater role in impacting the severity of prostate cancer. We see increased DNA abnormalities and hypermethylation. One of the problems is because of the lack of participation in genetic studies, tissue samples are very limited. And I'll speak about it later, how this is affecting our survival. We don't really have a lot of studies to answer the questions that I would like to see answered. One of the major barriers that we're seeing now as we move toward precision medicine is the lack of tissue. You need to give tissue in order to get genetic material. There was one recent study I found by Rensock. It looked at 72 global phase 2 and 4 clinical trials with almost 1 million participants. 96% were white, and 3% or less were African or Caribbean Blacks. That's terrible. And there was a recent study I found in the United States showing that all the clinical trials on metastatic castration-resistant prostate cancer grossly underrepresented Black men at less than 0.5%. That's horrendous. So the majority of the therapeutics that are being created basically for white people. We had our conduct conference last fall, and we had Peter Pinto, who is from the National Cancer Institute, Urological Solid Tumors Division, and he presented some data to us on a new genetic modifier. Some of these are called PARP2 inhibitors. They gave it to a series of white patients, and it downregulated the prostate cancer, creating a great response. But in the few Black patients they had, it made the prostate cancer worse. He also showed us the segment of the gene where they've been mapping out mutations related to prostate cancer. They've identified 80 plus for white men, and they've only identified 1 for Black men. And there's a whole Black area on that genome where they haven't got the information, but yet they're promoting drugs without knowing the true impact on Black patients. That's a problem. So I put this up just to highlight how heterogeneous Black people are. That's my ancestry DNA, and I don't know if how many of you have done it, but if you're a Black, you're going to find that you are a true mutt. I have over, oh my God, it's about 13 to 14 different genetic links. And then I have my wife's ancestry DNA. She's French. Very limited heterogeneity, which makes it much easier to map out as we move toward genetic like focused treatment. It would be much easier to treat her than a Black person. This has an impact on us when we try to be cross-matched for a kidney transplant.
Right,
We are
one way
very
home.
heterogeneous, so much more information needs to be gathered about us genetically before all of these treatments are released to the general public. Um, but money drives the system. So there are limitations of genetic testing in the current environment where most of the data is being collected on white patients. Um, so one of the big problems is allowing patients to self-report race. Matter of fact, race should not even be included. It should be genetically based categorization of patients. Just because you're Black, you may look brown in appearance. That doesn't say anything about your genetic code. So Rick Kittles, he is a Black geneticist. He worked on the Human Genome Project. He is now faculty at Morehouse School of Medicine, has illustrated some of the issues with some of these off-the-shelf genetic testing kits. So he looked at a couple that supposedly had African American prostate cancer cell lines, which if they really were that, they should have been over 90% African. But it's the opposite. They were 91% European genetic ancestry. So these tests aren't accurate. They don't have enough of our information to create accurate tests, which is why it is necessary for us to participate in clinical research. So there are clearly genetic and molecular reasons for the disparities in prostate cancer. Histologic and genetic data, like I just showed you, shows that prostate cancer in us is highly heterogeneous. Uh, and our genetic information contributes to the phenotypic and functional variability that we see in prostate cancer, like the increased Gleason score, the more aggressive presentation at lower PSA levels. Um, the biologic factors play a critical role in the early onset of prostate cancer and how we respond to treatment. Uh, I have plenty of Black patients that I removed the prostate. They have negative surgical margins, meaning that the cancer was contained. Lymph nodes are negative, and yet within 4 or 5 years, they may come back with a rising PSA and compare them to a similar white patient that had the same PSA, the same Gleason score, is less likely to happen. So there's something going on biologically that makes the cancer in us different, and we need to figure that out. There's something going on with androgen receptor signaling in Black men. Um, it's not because we don't have a lot of data. I'm not a geneticist, but these are the abnormalities that I've identified from a review of all the literature. Black men have increased androgen receptor proteins. We have increased androgen ligands compared to white men. We have shorter CAG or cytosine, adenine, guanine repeats. We have androgen receptor splice variants. Vitamin D deficiency is very prevalent in Black men, has some impact on the biology of prostate cancer. Um, the new treatments now, I have one. Uh, I guess you can't really see this, but I had a rep come to me just yesterday with a product called Xtandi. It's created by Pfizer, and it is an androgen receptor inhibitor. And they're promoting combining it with a new drug called Talzena, which is a PARP inhibitor. They haven't even adequately done the genetic coding to understand whether or not this drug is going to help us or hurt us. And yet it's already on the market and they're trying to promote it. And I had a pretty engaged conversation with her about how irresponsible it is to be promoting this drug and you don't have data in the high risk population. She left my office speechless yesterday. So these additional markers, FOXA1, SPOP, CHD1, in a couple of some of the Black patients, there are increased alterations, but they don't have enough data to really be able to figure out what it means, what are the implications. We see significant germline mutations in DNA repair genes in Black men, and it's associated with a higher risk of prostate cancer, higher risk of more aggressive prostate cancer. Um, I'm sure you all have heard of the BRCA genes, BRCA1 and 2. They're associated with breast cancer, but they're also associated with an increased risk of prostate cancer. Uh, the BRCA mutations are currently the best predictor of a response to chemotherapy like platinum-based agents and PARP inhibitors. But again, we don't have a lot of information. For those of you who don't know what a PARP inhibitor is, PARP helps a cell repair its cell wall and helps it stay alive. And so the idea is that if you block PARP in cancer cells, you'll stop them from being able to repair the cell wall and promote cell death. But turning off something in one group may turn on something in another. So unless you have the data to make sure that's not happening, it's not necessarily a safe thing to do. Uh, we see racial disparities and metabolic dysregulation. This has a lot to do with high fat diets and obesity, which appears to increase prostate cancer incidence and the aggressiveness of prostate cancer. It boils down to one thing. We found that when we do androgen blockade, which prostate cancer is a hormone sensitive cancer, it grows in response to testosterone. And part of the treatment strategies is to block testosterone. Once you shut it off, we found that some of the cancer cells have figured out a way to create their own testosterone. And it comes from this lipogenesis pathway. Uh, so it increased lipogenesis allows for cells to create better, stronger cell walls, create their own androgen, and create their own source of energy production. But we still need a lot of research to figure out what this means in Black patients versus white patients. So my take on it is we're seeing a rapid movement toward precision medicine. In Birmingham, where I am now, there's a partnership between the University of Alabama in Birmingham and Southern Research. They're about to build a huge precision medicine hospital, and the focus will be on using your genetic information to create personalized treatments. That's going to leave Black people out. It's hard enough to get us to participate in drug clinical trials. Now you're expecting them to trust institutions they don't trust, give up tissue. So if we're not in the room with this, we're going to get left out again and left behind. Um, so I think we need to focus on re-educating our primary care physician gatekeepers about the importance of screening and early detection and the use of PSA. Uh, if they're afraid of unnecessary biopsies, that is much less of an issue with the advent of the new MRI technology. Uh, my group, which has created the SCOPE African American Prostate Cancer Registry Trial, is going to be very active in trying to increase the numbers of Black men who are willing to participate in prostate cancer clinical trials. My other company is working on some novel recruitment technology using handheld technology like cell phones and working with faith-based institutions which have well over 40 million members to try to educate, recruit, and get more of us involved in clinical trials. And it's not just prostate cancer, this is across the board. All the therapeutics that we use are being created based on white people with limited data on Black people. The phase two drug creation goes through 4 phases. Phase two, 1 and 2 are critical in deciding on the dose and the side effects profile. And if no Black people or Hispanics or Asians are in that group, when it reaches phase three, the dose is set. So a lot of the problems are discovered in phase four post-marketing trials. But the dose is set, 50 milligrams, maybe it should have been 100 milligrams in somebody Black or 25 milligrams in somebody Asian. But once this hit the market, they're not going to go back and spend the money and make the changes. So our participation in clinical research is critical. I'm going to end my talk there, and any questions, I'm open.
Dr. Stoner, thank you so much.
Simon, I think you can stop the tape. Yep, thank you. So as you can see, Dr. Stone has a wealth of information and wisdom for us all. Dr. Walks, do you have any comments that you would like to make?
Dr. Neighbor Stevens, thank you. I at church, I was talking with some of the brothers about prostate cancer, and we have been. It's certainly impacted many people I know. The youngest person that I knew very well died from prostate cancer at the age of 42, and I think that in addition to early detection, early intervention of prostate cancer, one of the brothers I talked to was very, very diligent in his follow-up after he had surgery for prostate cancer, and a couple of years later has had a recurrence and is going to go back in for additional treatment. So I think that, like so many other things, it's very important that we get early detection, early intervention, but then don't get weary. Don't allow time to pass without continuing to be diligent in the follow-up.
Dr. Maxey, did you want to make any comments?
Yes, I think that one of my takeaways is that people who have first and second degree relatives, men, need to make sure that even though they haven't had symptoms yet, to begin the appropriate screening and look out, because the incidence of prostate cancer is so high in men who have fathers, brothers, uncles with this process. As Dr. Stone says, is genetically based. So that's something very important that we should pay attention to. And it's also not just a level of the PSA, but the rate and rise of the PSA. So very important to have it done at least 2 times to see what the curve is, what the rate of rise is, because it makes you at risk. Thank you.
Dr. Walks, I would just like to add on to your comments. I know that we're kind of in between in terms of season between family gatherings, but it is so important when we do have these family gatherings it's maybe an embarrassing topic for some people, but it's so important that we talk about what conditions our near and distant relatives have had, and if known, the outcomes, just collect as much family information as possible as we move forward in this era of genetic personalized medicine. You really are handicapped if you don't have your family history available to you.
Thank you. So we're moving towards the top of the hour. Are there any questions in the chat, Dr. David Stevens or Dr. Walks?
There is a question. I don't think that since Dr. Stone is with us that we really can answer it. It's a rather detailed question about prostate PSA numbers. I don't know, Dr. Walks, you have any comments you want to make on this?
I don't have the expertise to give a good answer. I think that
Why don't you state the question? I'll get the answer from Dr. Stone himself. We'll
Okay.
come back with it next week. What is the question?
Okay. All right, I will read the question. This is from Friends of Watts Tower. Number one, I challenged my urologist of my uptake trajectory on PSA graphs over a 10-year period. Quotes, if not doubling over 10 years with your history, no issue of concern, end quotes. To which I thought, well, suppose it doubles within 12 years. I still end up with higher numbers. Number two, I'm using prostagenics and gave up eggs to once per 2-week period and let go of a bunch of supplements except turmeric, ginger, and D3 and multivitamins. My numbers on PSA went down 1 point. Number three, is there a way to get pharma and NIH to fund with certain foundations a clinical trials access over an extended time for tissue sampling permission from patients and primary physicians? I know enough to know that those are very important questions, and as Dr. Maxey, you said, we certainly can take that back to Dr. Stone and get some input.
So let me take a check of some. Start at the bottom. Dr. Stone is working on the funding issue right now with NIH and other groups, so that is something that's ongoing. That's why he has the studies arranged that he already has, and he's seeking the underwriting to do that. Number two, he also did say that vitamin D is a major component of this. So we do, as we have on all of our shows, talked about increasing your vitamin D intake, which not only helps your immunogenicity, but also has to do with a reverse effect on prostate cancer. It helps you avoid it. So we do that. And turmeric is a similar agent. As to the first issue, it's not a matter of doubling over years. If this doubles over 6 months or 4 months, that's a problem. So it's not even that big a deal that it doubles in 10 years. You're going to be dead in 10 years. But I'm going to get these answers from Dr. Stone and get him back on either next Sunday or the following Sunday. Like I say, he's cruising in Paris right now. So very good. So thank you, Dr. Walsh. Thank you, Dr. Stevens. Any last words?
Well, I don't have last words yet, Dr. Maxey. I still expect to be around for at least another few months. But I do have another closing comment I would like to make.
Go ahead.
I've said this before, and prostate cancer awareness and prostate cancer screenings is such an important topic, and we shouldn't wait for a meeting about medical stuff. At the funeral of someone that I knew that passed away from prostate cancer, I got permission from the family, and I actually spoke about prostate cancer prevention and brought with me materials to hand out to folks at the funeral services. And it was very well received. It's not a typical part of a funeral to give a health presentation, but it worked. And a lot of folks were very grateful for the information. So I think whether it's a funeral, a family reunion, wherever the place is, if we can take information that can be relevant to the folks who are there, I think it's not a bad idea for us to be inventive in the way that we get health information to folks that we care about.
Very good, Dr. Walsh. That's the neighbor Stevens.
My closing comments are, we need to demonstrate our love for our loved ones and not just speak the love. And by that, I mean our significant others. If you know that your partner has not been in for a routine checkup, or you see things that you don't think should be happening or should be done, try to encourage them to go in and get the screenings and the checkups that they need. That's active love.
Thank you, Dr. Neighbor. Dr. Walks, that was a brilliant question you just raised about mortality, speaking at funerals. I think the three of us, and plus Dr. Hine, should arrange a meeting with the National Funeral Directors Conference and get them to adopt this as something that they do among all of those funeral homes across the country. That when somebody Black dies, that they figure something that's appropriate to the audience that's available, whether somebody speak or pass out literature. I think you hit on something right there. And this is a family reunion. So with that, I want to say thank you to both of you.
Dr. Maxey, Dr. Sherrod, I think we have about a minute or two, and Dr. Sherrod did raise her hand.
Go ahead, Dr. Sherrod.
Oh, good afternoon. I haven't seen you all in a while. I wanted to commend Dr. Stone on such an outstanding presentation. My question for him is whether he thinks that nutrition plays a major role in the differences that we're seeing in prevalence and outcome from treatment of Black men with prostate cancer. He mentioned obesity as a major factor. And so it gets back to taking responsibility for your own health. And, it starts with what you put into your body.
Well, thank you.
Thank you all.
So, Dr. Stone is not with us actually today physically. But
yeah, I know he's cruising in Paris, right?
Yeah, but everything you said is exactly true. Nutrition, lifestyle, exercise, what you put in your mouth, that's all about. But we're going to get those questions to him and let him come again. He's already spoken about 10 times, but we want him back.
He's excellent.
Yes, he is.
Very good. Very good.
Okay. Well, very good. Simon, I really appreciate you doing the research to pull this back out of the archives. And you're a gentleman and a scholar.
Well, Dr. Max, you're going to tell everybody to vote, right? Weren't you all fired up and ready to go with Kamala?
So we can't do politics, but we're going to vote for the people who are most likely to support the things that help us. And
exactly.
I do believe that even though we talk medical, I think that we should be behind certain legal minds that are former prosecutors. Anybody want to comment on this? We can use this last 1 minute to talk about that.
Well, I'm sure she can prosecute the case and lead us to a greater future, because the opposite choice that we have is going to take us back to a greater America, like back to picking cotton. I don't want to pick cotton anymore. Yeah. I grew up picking cotton for 2 cents a pound, 10 hours a day, making $2 if you picked 100 pounds.
Oh my goodness.
I don't want to go back there.
Somebody sent me a picture of her riding a shark chasing somebody up on the beach.
So
she's riding the back of a shark. So anyway,
Dr. Maxey, so Dr. Maxey, let me just add to something that you said, which is that we should vote for someone who we think will advocate for and put into practice the things that are important to us. And I think we have to know all the way from national elections to local elections, what people stand for, what people have said is important to them, so that we can vote intelligently And I think that if we are willing to do that work, we will absolutely make the right choice for the things and the people that we care about.
I'm going to ask Dr. Neighbor Stevens one more question. One of the potential candidates said something about people who don't have children should have less rights. And as a pediatrician, you know, people who do have kids, there are people who don't. But is there a social comment as a long-term pediatrician that all people, whether they have kids or not, have value?
That statement was so out there, I could not even begin to digest or unwrap it, or whatever the term is that you want to use. I could not follow that one at all. But without question, all people are of value. And whether or not they have children really does not enter into the basic humanity worthiness of us all.
So
Amen.
without being political, as we close this program, I want to solicit people to vote for former attorney generals from California. Have a great day, everyone. Thank you, Simon. Thank you, Dr. Walks and Dr. Neighbor Stevens.
Good day, everyone.
Bye.
Bye.